Hi, I'm Rachel, and I am Dr. Pevny's physician assistant. I'd like to welcome you to our Valley View webinar here this evening.
I'm Dr. Tom Pevny. I'm an orthopedic surgeon with Valley Ortho. I specialize mainly in knee and shoulder issues.
I'm Jessica McElroy. I'm a physical therapist here at our Glenwood Outpatient Orthopedic Clinic right here in the hospital.
We have a few housekeeping items to address before we get started. You can submit questions through the Q&A chat at the bottom of your screen. Your question could be answered live at the end of the presentation. We will try our best to answer your questions. We are unable to answer questions regarding personal health information.
Okay. See you soon.
Yep. Okay, so we're going to start with a presentation on knee stability and balance tonight. Okay, so before we begin, here's a good reminder. This content is only for informational purposes and should not be used in place of an actual doctor's visit. This presentation offers general evidence-based information not tailored to individual medical conditions. Consulting a healthcare professional is essential before beginning any new exercise or treatment to consider personal health differences. Here are our objectives tonight. We are going to learn the components of the knee and the mechanics that make up the knee anatomy and how they contribute to function. We're going to learn about factors influencing knee stability and balance to prevent injuries and maintain mobility. We are going to explore evidence-based exercises that can be done at home to improve knee stability and balance. And we are going to recognize signs and symptoms when professional medical assessment may be necessary. First, let's take a look at the knee. The knee is comprised of bones, ligaments, meniscus, cartilage, and muscles. The bones form the skeletal framework of the knee. Those bones are the femur, the tibia, and the patella. Next are ligaments, which stabilize and prevent excessive motion. The ligaments of the knee joint are the ACL, the PCL, MCL, and LCL. There are two meniscus, medial and lateral. These deepen the articular surface of the tibia, increasing stability and acting as a shock absorber to dissipate force across the joint. All the joint surfaces are covered with articular cartilage. Healthy cartilage provides a well-lubricated surface that allows smooth, low-friction movement between the bones. There are no blood vessels in the cartilage. Instead, synovial fluid in the joint capsule supplies the cartilage tissues with nutrients. For the synovial fluid to enter the cartilage and for waste substances to be transported out, the knee needs to be moved and to bear weight. The knee is a hinge joint. It serves critical roles in load bearing and locomotion, allowing for flexion, extension, and slight rotation. What is knee stability? This refers to the joint's ability to maintain proper alignment and prevent abnormal movements. Key influencing factors of knee stability include ligament integrity, muscle strength, and neuromuscular control. Ligament integrity refers to healthy connective tissue that is not torn or ruptured. Strong muscles provide dynamic support to the knee during movement, reducing stress on ligaments and acting as shock absorbers to the joint. Neuromuscular control is driven by the brain to control the muscles, responding to sudden movement and stress to prevent injury. Consequences of instability include pain, dysfunction, and a higher risk of injury during activities. Impaired proprioception, reduced postural control, altered gait mechanics, compromised neuromuscular responses, and inadequate lower extremity muscle strength can contribute to knee instability and increased fall risk. What is balance? Balance is maintaining or regaining the center of gravity over the base of support using sensory and motor integration. Efficient knee function provides joint stability and proprioceptive feedback, essential for balance during weight-bearing activities. Impaired knee function compromises balance and significantly increases the risk of falls in individuals. There are two types of balance. One is static balance, which is the ability to maintain a stable, motionless position while staying stationary. Dynamic balance is the ability to maintain stability and control while the body is in motion. Additionally, proprioception is awareness of where the body is in space. What are factors that contribute to instability in the knee and impaired balance? While within the body, we can look at ligament injuries, meniscal injuries, muscle weakness and impaired proprioception, and joint degeneration. Ligament sprains and tears, especially ACL tears, are frequent causes of knee instability in active middle-aged adults. Damage to the meniscus contributes to impaired knee stability and can result from trauma or degeneration. Weak muscles and proprioceptive deficits reduce joint support and affect balance and stability. Osteoarthritis and other degenerative changes commonly cause knee instability. Knee osteoarthritis affects 10 to 13% of people starting at age 45 and around 37% of adults 60 and older, leading to joint pain, instability, postural sway, impaired proprioception, and increased fall risk. Comorbidities affecting function and balance with your knee include diabetes, obesity, and neurological conditions. Diabetes impairs nerve function, contributing to poor balance and increased fall risk. Obesity increases mechanical loading on knees and accelerates joint degeneration while also shifting the center of gravity. And neurological conditions such as cognitive impairments and Parkinson's affect knee stability and balance through impaired central processing and motor response, compromising the ability to quickly adjust body position with environmental hazards. The confluence of these conditions worsens functional outcomes and reduces exercise intolerance. What about your lifestyle? That does matter. So sedentary lifestyles correlate with weaker muscles and poor neuromuscular control, leading to a higher fall risk and knee instability. Highly active individuals generally maintain better muscle strength and proprioception, but they may develop overuse injuries. Overall, individualized exercise programs will safely improve stability and balance for both sedentary and active individuals. So how do we work on this? An exercise program is most effective when combining balance training, strength training, and functional movement training. Walking is insufficient alone, but very beneficial when combined with balance training and strength training. Balance training includes standing in various positions or different feet positions and adding light movement. Strength training includes progressive resistance exercises focused on quads, hamstrings, and hip abductors. And functional movement training is movement that resembles daily activities using multiple joints and muscles. So we're gonna go through a couple of balance exercises on this screen, and then I will demonstrate for you. These are things that you can safely do at home. You can progress from feet together to feet a little bit apart to standing on a tightrope. You can stand on one leg, you can walk on toes and heels, you can walk on a tightrope, you can walk side to side. These exercises will improve your proprioception and reduce your fall risk. They can be adapted from beginner to advanced levels to safely accommodate various abilities. Safety at home doing these is the top priority. Therefore, you must consider standing next to a solid support, such as a countertop, and please also consider your footwear so you do not slip and fall. I'm going to demonstrate those now. So the first one I want to look at is if you are standing, again, this is going to be my countertop. It is a little bit too low. I'd like it to be here. And I'd like to have these shoes on because otherwise with socks, this would be a very slippery floor. But first I would go ahead and put my feet all the way together, creating a small base of support. And then trying to hold my balance, staying nice and tall with my posture and trying to see how comfortable that is. If this feels good to you and your eyes are open, because you're at home doing this safely, okay? The next one you would go to is called semi-tandem. So your feet are gonna just kind of hug each other in the curve there, the arch in your toes. So they're off just a little bit. And again, you're gonna stand nice and tall. Your hand is at your countertop. You're gonna try to maintain your balance. How long, that really depends on your ability. We don't have a time goal here. We wanna challenge ourselves. We wanna switch and do the other foot. So you want to make sure you do both feet. Sometimes one side will feel easier than the other. Just like you have a dominant upper extremity, you might have a dominant lower extremity as far as your strength. That depends on your history of movement. So one side might feel easier than the other. Then the next would be a complete tandem, which is going to be one foot in front of the other. So you're kind of walking on a tightrope here. But now we're going to try and hold it nice and tall. You want to make sure your weight is right in the middle. So not shifted all the way to the front, not shifted all the way to the back. Center between both. Again, nice and tall posture, looking forward, not looking down. If you look down, the center of gravity that we talked about earlier is going to shift forward, and then we're not going to keep our balance. And then switch to the other foot and maintain that nice and tall. Holding on if you need to. If you feel good, maybe your hand hovers above, but it stays right there to catch you if you need it. I really don't want you guys trying this at home and then falling. That would not be worth the training, okay? The next one is single leg stance. So if we can do all those, can we try standing on one foot? Nice and tall. I want you to think about your big toe pushing down. That helps stabilize you. And then same thing on the other side. And a good way to challenge yourself is, this is comfortable. Can I lightly lift my hand up, and how long can I hold it for? And then if I work on this regularly, am I able to hold it for a longer duration? And then my balance is getting better. The next thing would be heel walking. So you're going to literally go on your heels. If you have sensitive feet or heel pain, you might want to do this in your shoes to have a little cushion. And then you're trying to walk just on your heels, maintain your balance and work those muscles in your lower leg. And then right next to the countertop. And then there's also toe walking. So you're going to go all the way up on your toes and you're going to walk here. Okay. Then we can do tandem walking. So now I'm going to walk on that tightrope. One foot in front of the other, nice and tall, right next to my countertop with my safe shoes on. My eyes are still forward. I'm not looking down so that I'm not shifting myself forward. Okay. And then the next one is going to be tandem or lateral walking, excuse me. I'm not going to face away from you. So let's pretend my countertop is here and I'm just going to sidestep. How does that feel to you? If you have any dizziness or lightheadedness, anything like that, we need to stop and reassess. So make sure you're safe when you're doing this. But I'm holding my countertop and I'm sidestepping. So those are some balance activities that you can try at home, and it doesn't require any equipment. Okay, now let's go back to our slides and we'll talk about strengthening. Okay, so our strengthening exercises want to focus on our key leg muscles, our quads, which are the muscles on the front of your thigh, your hamstrings on the back of your thigh, and your hip abductors, your side glutes that help stabilize the top of this whole chain. They all help support your knee joint. So the stronger they are, the more stable you're going to be as far as a muscular component, knee stability. There's exercises that we're going to go along here that help enhance muscle endurance and stabilize joint kinematics. So let's go through those exercises now. We'll grab this chair. This is one of my favorite exercises. This is called sit to stand. You're going to get a chair at home that is not on wheels. If you have a hard time with this, you might want a chair that has armrests. You're going to come to the edge. And if you can we stick those hands out here? And then can we stand up? But then the second part of it is that we don't flop down. We want to slowly control that. Up and down. I don't know, maybe we try 5 in a row. This is a really important movement. If you can't get out of a chair, you're losing your independence. So, and this is also a nice entry to squats, because squats can hurt our knees. So this is a much safer way to do them. There's plenty of people who've got to use the armrest, and that is absolutely okay. But if you are unable to get off of a chair like this, we want to build that strength a little bit. You might start with your hands here. And then a way to progress that, if you're comfortable with no hands, is to find a lower chair, because I want you to be able to get off a low toilet or a low couch with good leg strength, and your knees not giving way. So that's your sit to stand exercise. The next one is called a straight leg raise. So this one you would want to do, you can do it laying in your bed, no need to get on the floor. You're going to go ahead and lay down. Both legs are straight initially. But then let's bend one leg. This leg is gonna, with it bent, is gonna support your low back so you don't strain it. Squeeze this quad muscle, squeeze the muscle on the front of your leg nice and tight. Then keep it tight as you lift up to about equal with the other leg and back down. You really wanna make sure this is squeezed the whole time. And you lift, and then you'd switch to the other side. And you do however many reps is comfortable, maybe 10, it depends on your ability, right? So that's a great exercise to do at home. The next one would be what's called a long arc quad. So you can do it sitting in any chair, and you just straighten your leg out and bring it back down. And this is gonna work this quad muscle on the front. This is a muscle that does a lot of work for your knee, as well as your hip. And then same thing on the other side. It does not, people often ask about their foot. It does not matter if it's pointed or flexed. We're really focusing on squeezing this muscle here. Okay. Hip abduction. So we want to work these hips. So I'm gonna use this chair to show how you hold on to the counter. Because again, I don't want, this is not a balance exercise. I'm gonna show it from the side and then I'll change directions. I wanna stay nice and tall. I'm gonna work my outer hip. My toes need to stay forward and my knees straight. So I'm gonna lift like this. What I don't want you to do is turn your foot this way or start swinging it backwards. Okay, I want you to keep it straight out. And then I'll go this way. I'm gonna move this out of the way so you can see, but again, if I was holding onto my countertop for safety, I'm gonna lift here. That's about as far as you need. You do not need to lift all the way, and you don't want your trunk turning like that, right? So here's my counter, I'm lifting. Let's do 5 to 10 reps, and then we're gonna switch to the other side. We wanna work both sides. Your standing leg will get tired also because that same muscle is what's holding you up and stabilizing you right now, while this one is contract, relax. So it's okay if you feel it on both sides. Again, this is not a balance exercise. Please hold on to something. That's really important. And then the next one is heel raises. So again, I'm holding my countertop on a very steady chair, and I'm going to go up and down to work my lower legs. And then I can do toe raises as well, bringing those up. What you really want to pay attention to is your hips. We do not want to go flying backwards. That's not working your lower leg. So some people do this standing against the wall and trying to lift from there so that their body doesn't go swaying in the wind. And then the last one is let's try mini squats. So squats often hurt people's knees. How can we do that safely? Well, let's try hip width apart. Our toes are forward. And we have that chair. You might even have the chair behind you, right? So if we try that with the chair first, because what if you go down and you can't get back up, okay? What if we go here and we squat, but I'm not sitting in it, okay? Just sticking my bottom backwards like I'm gonna sit in the chair. I want you to notice my knees are not flying past my toes. They're staying above my feet and they're not diving in. So I'll show you this way as well. Okay. I'm sitting back, my knees are staying in line. I'm coming back up, nice and tall, controlling. If that hurts your knees, let's not do that. Let's go back to the sit to stand, but that's something you can start to build on is working squats. Okay, let's go back to our slides so we can talk about functional movement, the third component of our training. So it's important to include balance and strength work that moves in the pattern of functional movement. What is functional movement? Those are daily activities that you do over and over when you are doing things that you do not consider exercise. Examples that we're going to do tonight are step ups and stepping over obstacles of varying heights. These mimic real life movements, providing specificity of training so that we can directly address our movement patterns and make them better with what we do every day. So let's go ahead and demo those. So step ups first. If you don't have a step at home, and that's fine, most people do. What I would like you to do is consider going to, if you have stairs at home, the bottom of your stairs, okay? Because if you lost your balance, let's not be on the top of the stairs. And I'm gonna hold my handrail. I'm sorry I don't have a handrail here, but I do want you to hold on. This is not a balance exercise. And then you're going to go up and come back down. And you're gonna do this repetitively to build that strength. The balance comes from your whole body. So this is not a firm grip. It is a light grip on the handrail. And then I'm going to repeat on the other side. If you do have something at home that is sturdy, some sort of step, again, you can use that, but let's make sure you have something nearby to hold on to. I don't want you to worry about your balance on this. So that can be really helpful, is working on step ups. And then as far as walking over different obstacles, so I'm going to use cones. You probably don't have cones at home. That's okay. You can grab a plastic water bottle. You can grab, I mean, I've seen people use like their oven mitts, like just something you can put on the floor. It's not tall. I'm going to put these sideways. So nothing big and nothing fancy. Like you have stuff at home you can use. You do not need to spend any money. And let's put them near the counter again, okay? Everything's by this counter. And then can we step over them to work on our dynamic balance or proprioception where we are in space? At first, you might be watching where your foot goes, but then you might eventually be able to look up a little bit, and that'll challenge your proprioception where you are in space. Just don't look straight down. That'll shift your weight forward. So that's a great one to work on. You can also do that sideways. If this is my countertop, I can step over this way too, okay? That's really helpful. Okay, let's go back to our slides. Okay, so where do we start? How much? How much do we do? How often do we do it? Evidence suggests starting low intensity and low frequency, such as 2 to 3 times per week at tolerable levels, then gradually increasing sets, repetitions, and complexity as strength and balance improve. Progression should be individualized, monitoring for pain or instability as indicators to adjust what you're doing. Again, safety with movement at home is the top priority. Additionally, research shows that walking 2 to 3 times per week can complement an exercise program for improving strength, balance, and stamina. Remember, walking is insufficient alone. So if you're going for walks, great. Let's pick up the strength and balance work as well. Okay. Okay, this is the most important thing. Your exercise program should be tailored to you. Exercise should be individualized based on your ability, pain severity, fear of movement, ease of access, safety, and other health concerns. Exercise should be incorporated into your daily life for long-term adherence. Consistency matters more than specificity of what you do. One size does not fit all, so please listen to your body. When should we seek help? Flags prompting professional medical evaluation include persistent knee pain and swelling, repeated episodes of giving way, inability to perform daily activities and/or recreational activities, or failed response to consistent home exercises. That keyword consistent is really important. Please try to work on things for quite some time to give your body a chance to grow, adapt, and progress. Early intervention with physical therapy can improve your prognosis and your function. You may need to start with your primary care physician, who can determine if a referral to physical therapy or Valley Ortho is appropriate for your given situation. How can physical therapy help? Well, physical therapy includes personalized interventions to address impairments in muscle weakness, movement compensations, and flexibility deficits. Research demonstrates that customized physical therapy programs enhance recovery, reduce pain, and improve functional outcomes compared to generic exercise programs. In summary, understanding knee anatomy and the factors influencing knee stability and balance is crucial for middle-aged adults and older. Safe, evidence-based exercises and knowing when to seek professional help can significantly improve knee health and overall well-being. Empower yourself with this knowledge to maintain an active, balanced lifestyle and reduce the risks associated with knee instability. Okay, I'll grab them. We'll start on some questions.
Hello, everyone. I thought that was a great summary and talk, and a lot of what Jessica was saying is really important for, preventing injuries, obviously. And I can tell you this, that what she went over in the physical therapy part of it, even though I'm a surgeon, most patients that I see in the office I end up sending to physical therapy, and most of them do get better. So what you do is not great for my business because we like to operate, but the good news is most things do get better with physical therapy and not operative treatment. So I think what she went over is very important. And one of the perfect examples of that is ACL tears,
right? Because
we see a lot of anterior cruciate ligament injuries, especially this time of year with skiing, but we see it from skiing, also start-stop pivoting activity. And women are much greater risk than men of developing an ACL tear. And that's multifactorial. A lot of reasons behind that. But one of them is because one of the topics today was alignment.
Mm-hmm.
And, women, because they give birth to human beings, they have wider pelvises than men. So they have what we call a valgus or a knock knee alignment compared to men. And even though the main reason women are at increased risk of getting ACL tears is because of lack of neuromuscular control and studies, that's well documented in the literature. And because of that, probably over 20 years ago, we started implementing ACL prevention programs aimed at that neuromuscular control and significantly decreased the incidence of ACLs in the high-risk individuals. But the point I'm getting to is that one of the other risk factors is that knock, knee, or what we call valgus alignment. Because when you come down, you don't have good neuromuscular control, that's going to put a lot of stress on your ACL and can cause your ACL to tear. So that's a good example of where the neuromuscular control and alignment is very important.
All right, first question. What could be the reason for not being able to straighten your leg completely without sharp pain at the base of the patella in a highly active person that does not have an acute injury?
Okay, so we call that a flexion contracture. And age matters, obviously, because one thing that can lead to stiffness is if you have degenerative changes or arthritis in the knee. And sometimes that can cause you to be unable to fully strengthen or fully straighten. And because of that, that can put increased stress on what we call the extensor mechanism, which is your quad muscle, quad tendon, patellar, and patellar tendon. And that can lead to a patellar tendonitis kind of issue. So one is because a normal knee, one of the structures that Jessica talked about is the articular cartilage, and it should be very smooth. It's like ice on ice. And in a normal knee, when you straighten and bend, there should be no friction. But when that wears out, it's like sandpaper on sandpaper, so you may have difficulty straightening. So that's one reason why you can't straighten, and then that's going to put increased stress on your patellar tendon. Another reason could be if you're a young, active individual who's a runner or does a lot of jumping, it could be because of pain. You just don't want to get it there because it hurts too bad to get it there. But that's where, when you come in, we do a good physical exam, we watch your gait, we get imaging, and we're able to figure that out pretty quickly. Any other questions? But one thing about the alignment, let me just talk a little bit while we're waiting on another question, is that not everybody's alignment's the same. We're all different. So, and we really don't know what the long-term consequences of having kind of a knock knee or a bow leg deformity is with time, because that may be normal for some people. The alignment is something we always check. Where I see it a lot of and where it becomes really important is in my total knee patients, people that we do knee replacements on. Because when people start getting arthritis and one part of the knee wears out, they're going to get malalignment or angular deformities in what we call the frontal plane. There's different planes to the knee, but that's the main one. That's what we're looking at when we look at someone from the front. And so that's something that we want to correct when we do a knee replacement. So alignment is really important in my practice, mainly when I'm seeing those middle to elderly patients whose knees have worn out. We're going to do total knee replacements on. And that's a really hot topic these days, because traditionally we would want to correct everybody to neutral in what we call the mechanical alignment, but we're starting to find out that not everybody's knee is lined up the same. So with new technologies such as computer navigation and robotics, what we're trying to do now is really individualize the alignment, because we know that's important for the long-term function and the long-term survival of those implants. So the alignment I may put one individual in may be different than somebody else, just based on what their native alignment is. So alignment's really kind of a hot topic these days in the total knee replacement world.
Got a couple more questions. When is it too late to repair a meniscus? What are the signs?
You want me to take this one? Meniscus tears are pretty common. And you brought up repair. We do try to repair. Repairing means that we put stitches in it. And the meniscus is very important. As Jessica said, it's an important shock absorber. So one of its main functions is it helps protect that smooth cartilage on the end of the bone. So then the other function is it does give us stability. So some tears, if they're in a part of the meniscus that has good blood supply, we try to preserve, and we do everything we can to repair those. So it's never too late to repair it. But if you do have a meniscus tear, and it's been there for months or even years, then you're really going to kind of trash it. And once we get in there, it's probably not going to be repairable because it's not going to be a clean tear. So in that situation, we end up doing what's called a meniscectomy, where we just trim up the meniscus. So you end up with less meniscus, but it's not rough. So we smooth it out. And that's probably better for your knee than having that rough surface of a tear in there. So it's never too late to repair it, but the longer you wait, if it is repairable, it may be irreparable in the long run.
An attendee has patellar tendinitis. Can you talk more about where that pain would be and how much success and healing that has with physical therapy? This attendee is a ballroom dancer. Is there any knee issues that dancers get more often?
Oh, interesting. Okay. Well, so if you're looking at the patellar tendon, okay, you're probably having a lot of pain, just isolated right through there. First, have you looked at your quad length, right? So as your quad contracts, it's going to pull that patella up towards you, your kneecap up towards you. And is there any tightness there? And that includes up into the hip. So first we want to look at up the chain. So when you walk in and I'm looking at your hip, I know you're coming for your knee, but the whole chain matters. So if you've got tightness up above, it's going to impact your knee. Then we're going to look at your strength. How are your quads firing? How are your lateral glutes firing? Those hip abductors that we talked about earlier. The strength of those contributes tremendously to how your knee is functioning, especially when you're doing weight bearing, repetitive weight bearing activities. As far as physical therapy, great, please come in. We would love to help you with that. We're going to look at all of that. We actually have a really great therapist who was a professional dancer. So we have a great fit for somebody who understands that specific movement pattern. That's a great thing about our clinics. We have such a variety of backgrounds. We have an individual whose name is also Jessica, who was a professional dancer. So I am sure she would absolutely love to help you with that.
And one thing I would add to that is that most people, as Jessica said, do respond very well to physical therapy. You know, like if you see me in the office and you have patellar tendonitis, which is really micro tearing of the tendon right underneath your kneecap. We also call it jumper's knee. It's a pretty common condition, and all the things that she talked about are factors that can lead to increased stress on the patellar tendon, including tight hamstrings can do that. So all those things. But if you don't get better with therapy, there are some other things that we can do as surgeons. And one of the newer things that we're starting to do is do what we call orthobiologics. So if you don't respond to therapy, icing, over-the-counter medications, patellar tendonitis does respond pretty well to PRP injection, which is platelet-rich plasma, where it's an office procedure where we draw your bloods, spin it, isolate these cells called platelets that have a tremendous amount of growth factors. And that's been shown to be effective for patellar tendonitis if it's recalcitrant.
How often can you get steroid shots before they will no longer be effective?
Steroids are probably the most common things that we inject into the knee. I'm going to use the knee as an example here. And we do it mainly for inflammation. Steroids are very strong anti-inflammatory, and mainly for individuals that have arthritis or degenerative changes where that smooth cartilage wears out. And historically, cortisone has kind of gotten a bad name because if you do too much of it, it can actually be what we call chondrotoxic. It can make that cartilage on the end of the bone wear out quicker. So we're pretty careful about how often we do it. I think it is okay, though, to do just to settle the knee down, especially in individuals who have a swollen knee. I probably wouldn't inject more than 2 or 3 times a year, but there are newer cortisone-based injections now. There's something called Zilretta, which is a long-acting, slow-release steroid. So we inject it just like we do any injection, but over time, there's little microgranules that release low doses of steroid that are probably safer for your cartilage. And you can do that every 3 months. I've had patients that I've done the Zilretta injections on for years. So everybody's different. But it's just like any other drug. Sometimes you can build up a tolerance. But the main problem with arthritis is that it's progressive. So these injections don't cure it, they treat the symptoms. There really is no cure for arthritis except for a knee replacement. But many individuals can go years by doing cortisone injections. And if they don't respond to those, we have other options, such as hyaluronic acid, which is more of a lubricating injection. And also then the orthobiologics, the PRP works very, very well in individuals that have early to moderate arthritis that haven't responded well to the other injections.
Can weakness in one knee cause damage in the opposite?
Well, it's gonna change your mechanics, right, of how you move every day. We're not exactly 50-50 in how our strength and our flexibility, but if you have one side that is getting progressively weaker, maybe you've got some pretty good knee arthritis and the whole leg is just wearing out essentially. When you come into therapy and you have knee arthritis, that's not what you asked, but that's what I'm thinking at first with weakness. We're gonna fine tune the strength on that leg because your mechanics will compensate how you move, how you get up from a chair, how you walk. Your body will find the easier path to get there, even if it's not the healthiest path. So yes, I think it will trickle into potential issues depending on how much weakness and then how abnormal your movements become.
And that's kind of getting back to the previous question of the steroids. That's one reason I have no problem using steroids, because we want to get that fluid and inflammation out of the knee. Because it's well documented that if you have swelling in the knee, there's a reflex between your knee and your quad is going to shut down. So if you have anything, most common is arthritis, like Jessica said, but you have other conditions that cause chronic swelling. At least in my office, one of my priorities is to figure out what it is and get that swelling out of there, because it is going to lead to weakness in your quad, and that's going to lead to other issues.
So regarding over-the-counter braces, are there ones that are more effective for knee stability?
I think you should strengthen your muscles. Certainly certain situations, you're gonna go for a hike and you want to throw a knee brace on. I think there's benefit in that. I think that you should work on your strength consistently. I can't give you, I mean, maybe you guys can, I can't give you a specific brace I'd throw you in.
To me, the over-the-counter braces are like supplements. There's millions of them out there, and you really don't know what the best one is, because one, they're not, like, supplements aren't FDA regulated. So, whatever you're getting in those supplements, you have no clue if you're really getting what you think you're getting. There are some that are better than others, and the same thing goes with bracing. There's a ton of braces out there. Over-the-counter braces, I will tell you this, there's what I do like are the neoprene or the cloth compressive sleeves. They're not going to give you much stability, but what they do is I think they help with some of that neurofeedback. And they're, so you're aware that, that's your knee, but they give you also a little bit of confidence, which may be good or bad. But I think it could be helpful in that sense. If you need a brace that's going to give you support, like such as a hinge brace with metal, then I would recommend coming in and getting evaluated, because we have much better braces. Even our off-the-shelf braces are better than what you're going to get at a drugstore or a store like that, or City Market, et cetera. But also, if you're malaligned, again, that alignment concept, there are some braces called unloader braces that can help correct that alignment if your malalignment is your issue.
We have a handful of questions about PRP. If you could maybe expand on that and kind of explain what it is, what the process is, do you recommend it?
Yeah, I'm a big fan of what we call orthobiologics. I have been for a while. I've been doing it for a long time. And, just in a brief summary, we're going to take knee arthritis. So there's really four main injections that orthopedists do. The number one is cortisone, which we talked about, steroids, which are strong anti-inflammatory. Number two is something called hyaluronic acid, which is more of a lubricating substance. So I'll do that in someone that has arthritis and pain, but really maybe not much swelling, because they don't need that anti-inflammatory effect. And then we get into what's called the orthobiologics. And I'm skipping some other injections that other people may do, but we don't really do in our practice. So the really the workhorses are cortisone, hyaluronic acid, and really that's kind of dictated because that's all that insurance will pay for, and sometimes they're very resistant to even pay for those. And then the orthobiologics generally are not covered by insurance, so it's out-of-pocket pay, but they can be very helpful. And the two main orthobiologics are PRP, And there's a ton of literature that supports it for arthritis and other conditions such as tennis elbow, patellar tendonitis that we talked about. And then there's also stem cell injections, which are a different type of orthobiologic. But the least invasive is the PRP. And what we do is if you're a candidate for that, you come into the office, Rachel here, or one of my assistants will draw your blood. We typically get either 60 or 120 cc's of blood. And then we have machines called a centrifuge, which spins the blood and it can separate the cells from one another and the fluid from the cells. So we isolate these cells called platelets, and the main function of platelets are that when we cut ourselves, they help coagulate our blood so we don't bleed. But they've been found to have a tremendous amount of growth factors that increase blood flow to the area, significantly decrease inflammation, and they basically just make your tissue stronger. So they're very effective. And we inject it just like we would a cortisone injection or a hyaluronic acid injection. A lot of times we'll do it under ultrasound guidance to make sure we get it into the right place, and you leave. So studies have shown, though, that people that have mild to moderate arthritis, if you get a PRP injection, but the most important thing about PRP is the quality of the platelets. So there's a bunch of different companies that want to sell us their centrifuges and use their product. But it's very, very important to get as much platelets as possible. So we know that the threshold is about 6 billion cells. So you want to have over 6 billion platelets that you inject, or it's going to be worthless. So we've actually been looking, ironically, at a couple of companies recently, which gives us 10 to 12 billion cells. So it's really high quality concentrated platelets. And now it's getting so sophisticated that not only are we injecting platelets, but there's these proteins that we know are very strong antioxidants, anti-inflammatories, alpha-2 macroglobulin, something called IRAP. And so what we can do is we can take the fluid that we separated from the cells, and we can go back and filter that fluid and isolate these proteins and inject those into the knee at the same time, same injection. So the technology is pretty amazing these days, and it is very effective. A PRP injection in the knee is probably about $1,100, I think. Is that right?
Yes.
So it's about $1,100, which in the scheme of things, that's going out to dinner and Aspen. So it's really not that bad, if you look at it on a relative scale. But the studies have shown that if you get a good quality PRP injection in your knee, it can give you relief for up to 15 to 18 months, which is pretty significant. So you're going to get better relief and longer relief than you would with just a steroid or the hyaluronic acid. The other ones are stem cell injections. Stem cells are a little bit different. They're also very effective, but it's a little more invasive if you're going to do it the right way, the legal way. Most of the time we get it from the pelvis. We put a needle in, and basically middle of the bone is like blood. So it's like drawing blood out of the bone, but then the process is the same. You spin it in a centrifuge, isolate these stem cells and inject them. What I would be wary of is any kind of birth product stem cells. Like there's a lot of people that advertise umbilical cord, placental, Wharton's jelly. These are all birth products. Those are really not approved by our government, by the FDA, to inject. And there are some studies out there that have looked at those type of stem cells, and there's minimal stem cells in those products. So I've had people tell me they've had them and they do great and they love it, and I don't say anything, and it may be a placebo effect, but if you want to go the stem cell route, I would use your own.
What are new developments or technology that are promising or that you're excited about?
Me? Everybody's excited about AI and what it can do for healthcare. One of the things we talked about earlier is the alignment in knee replacements, and I think that's a very big, big topic right now. So now with computer navigation and robotics, but you don't really even need that. Getting the alignment just right, understanding that not everybody is the same. Historically, we would go about what's called the mechanical axis, where we would draw a line from the hip that would go to the ankle, and it should go in the middle of the knee. And that's how we would try to line up our total knees, but we have found that that doesn't work for everybody. So what we're trying to do now is customize the knee for every individual to do either what we call a functional alignment or something called kinematic alignment, where that alignment is specific for that individual patient. And I think ultimately that is going to do better than what we're doing now. So, and some of that technology, the computer and the robotic technology will allow us to do that to the 0.5 millimeter or less. The other thing that I'm very excited about that we've done quite a bit of this winter is we were talking about ACL injuries earlier, and is the way we treat ACLs. So I'm a big believer in preserving our natural anatomy. So rather than take it out and replace it with something else, why not try to save it? That way our knee, for example, is going to feel like our own knee. We're going to have that same proprioception balance sensation that Jessica was talking about. So in the right individuals, what we're doing now is we're doing ACL repairs, which historically didn't do well, but with the newer technologies, the newer products we have, the fixation devices, and we're talking about orthobiologics, the new biology we have to help them heal. Studies have shown that they're doing just as well as doing a reconstruction. So historically, the gold standard for ACL tears was to do what's called a reconstruction, which basically just means that we use other tissue to act as a substitute for your ACL. So we would take your ACL out. Now, if the tissue is good, we're able to go in there and put stitches in it and repair it with the products we have now, which weren't nearly as good as they were 20, 30 years ago when all the results weren't good with that procedure. So technology has been very helpful for that. And then we put in what's called a BEAR implant, which stands for Bridge Enhanced ACL Repair, where we put in this collagen scaffolding, for lack of a better term, and we put that right around the ACL, and that helps that ACL heal back to the bone. And I've had patients that I've done a reconstruction in one knee and then a BEAR, because I wasn't doing BEARs and repairs at that point, and a BEAR in the other knee, and they say it's night and day the way their knee feels. So there's definitely something to that, and that's something I'm pretty passionate and definitely also excited about as well.
This attendee has been told that they do not have cartilage in their knee. Is there a way to replace the missing cartilage? This attendee also highly recommends PRP. They had it for their plantar fasciitis and it worked great.
So they had PRP, and is there a way to regrow cartilage? Yeah, that's a great question, because when we talk about regenerative medicine, which is also kind of a generic term for like this orthobiologics, people think this regenerative medicine is going to grow cartilage. It's not, okay? Once you've lost that cartilage, it's not coming back. You've all seen the x-rays on the internet where it's bone on bone and they inject stem cells and it looks like a normal x-ray. That does not happen. So again, even the PRP and stem cells aren't going to cure your arthritis. They may slow down the progression. They're going to help with the symptoms. They're going to increase blood flow to the area, decrease inflammation, maybe make what's left of your tissue a little bit stronger, but they're not going to replace it. And I'm glad you got better on your plantar fasciitis with that PRP, because that's one area that it really does not work that well. So, so you're lucky. So I'm glad it worked for you. It can help. It just doesn't work as well as some of the other places. But there's really no way to regrow the cartilage. Just to kind of summarize your question.
Is negative extension in your knee okay? Or is the goal to have zero extension for best long-term function?
Well, I think your natural knee does hyperextend so that you're like supported in your gait pattern when you go and you're standing in your gait and you're going to push off, you do hyperextend. So if we are rehabbing someone after ACL surgery, we are trying to get them into negative extension, so past 0 degrees, oftentimes between 5 and 10 degrees. If you get a knee replacement, we're going to get you to 0, and that's good as long as you have really good quad control. So those are my 2 examples on that. But naturally, you do have hyperextension to some degree.
I want to quickly go back to that cartilage regeneration, because I want to make myself clear. What I was talking about was for a degenerative knee, someone who has arthritis and generalized global wear and tear. Some people do have what we call a focal cartilage deficit. If you're a young person and you have a normal knee, good stability, and you have an injury where you have a full thickness defect to that cartilage, but the cartilage around it is healthy, then yes, we can put cartilage into a focal defect like that. But most people that have arthritis, globally, there's not a lot we can do for that.
Okay, just a couple more questions. How long after a meniscus repair, let's say worst case, will I be able to sail a catamaran across the ocean?
Well, you can do it, the day after if you're on crutches and a brace and not putting weight on it. But you probably don't want to do that. Yeah, meniscus repairs, because meniscus doesn't have great blood supply. There's a lot of stress on the meniscus. There's compressive, there's tensiles, there's shear stress on it. So, they don't, some of them don't heal great. We do try to preserve them as much as we can. So even though the surgery is an outpatient procedure, the rehab is kind of a pain in the butt with a meniscus repair. Because ideally, with a meniscus repair, we'll put you in a brace. We're going to want your knee kind of locked straight in extension. You're going to be on crutches. We don't want you to put weight on it for about 6 weeks. In therapy, when you're not putting weight on it, they can start moving it.
Yeah.
0 to 90, and they'll work on isometric strengthening so you don't lose your strength and all that kind of stuff. And they can do different modalities as well. But for a meniscus to heal after repair, I'd say minimum 3 months, especially if you're on a boat and it's a slick surface, and the motion of the ocean and all that kind of stuff is going to put stress on it. I'd say minimum 3 months, probably more likely 4 to 6.
And if you come into physical therapy, we ask you what your goals are. What are you getting back to? Please share that detail because we can help with specificity of rehabbing you. But I tell all my patients, it's my job to prep you and get you ready. It's their job to clear you to go do that. I want to make sure you're healing as expected from all your team members.
And Jessica and Dr. Pevny and Rachel, where do you guys see patients?
I'm here at the Glenwood Clinic inside Valley View Hospital. We have rehab services on the 3rd floor.
And Rachel and I can speak for Rachel, because we work together closely. We see patients, we're kind of the Up Valley, Valley Ortho team. So we see patients, we have a very nice office, quaint office there on Main Street in Aspen. We also see patients in our Willits office right across the parking lot as you're leaving Whole Foods. You're looking right at us. We're on the 2nd floor there. And then we also operate in our Willits Surgery Center. And I come down here to Valley View and I operate down here once a week as well. But as far as seeing patients, we're Mid-Valley and Up Valley.
I want to throw in though, we have 6 physical therapy clinics. So I'm here in Glenwood, but we have one in Silt, in Newcastle, Glenwood, Eagle, Carbondale, and Willits. So no matter where you are in the valley, we've got somebody who can see you. But if you're in Glenwood, I'd be happy to help you.
All right, that is going to wrap up our webinar tonight. Some end of webinar announcements. Our team would love to hear your feedback on today's presentation. If you have the time to fill out a quick survey, it will appear right after the webinar has ended. You will receive an email with the recording and a PDF of the exercises you saw tonight within the next 24 hours. The next Valley View University is March 11th at 12 p.m. with interventional gastroenterologist Dr. Bob Edemad. He will be presenting on how gut health supports longevity. Thank you all for joining and have a great evening.
Thanks.
Thank you. Thank you.